Welcome to a special Pediatric Psychopharmacology series of the NEI podcast, hosted by Dr. Jeffrey Strawn. Dr. Strawn is a professor of pediatrics and psychiatry and behavioral neuroscience at University of Cincinnati College of Medicine, with expertise on mood and anxiety disorders in children and adolescents. In this series, he will engage with fellow experts to discuss important issues related to pharmacological treatments for psychiatric conditions in pediatric patients.
I'm Dr. Jeffrey Strawn, and welcome to another edition of the Pediatric Psychopharmacology series. Today, we're going to be talking about lithium in child and adolescent psychiatry with my good friend and colleague, Dr. Adelaide Robb. Dr. Robb is a psychopharmacologist who specializes in mood disorders, anxiety, and attention deficit hyperactivity disorder. She's also the chief of the Division of Psychiatry and Behavioral Sciences at Children's National Hospital in Washington, D.C. Welcome, Dr. Robb.
Thank you so much for having me, Dr. Strawn. It's a real pleasure to be here to talk about pediatric bipolar disorder and lithium.
Let's get into it. And I'm really excited about this because for me, lithium is one of those medications that when I use, I always ask myself, why didn't I do this 6 months ago? Because it always follows 3 or 4 failed trials of something else. And in many cases, I'm able to get the patient better with lithium. I guess that raises a really interesting issue, which is why don't we use lithium earlier? Or is this perhaps just my practice?
I think a lot of it is fear. And by that, I mean it has a narrow therapeutic window. It has drug-drug interactions with things like nonsteroidals. You have to be really careful if somebody's got influenza or a high fever and they're getting dehydrated. And it has GI side effects. And that's very different than an antipsychotic where you don't need to get blood levels. You can give it once a day instead of BID. And you don't have to change dosing as the level changes.
So some of it is really convenience as well.
And rapidity of action. So if we look at our antipsychotics for bipolar, we can get a treatment effect in 1 to 2 weeks if you titrate aggressively on an inpatient unit. But to get the full benefit of a lithium trial, you have to get that serum trough level up to 1.0, and it takes about 4 to 8 weeks before you're going to get the full benefit.
So not only is it a convenience issue, it's a patient's issue, a PATIENCE issue, as well as a clinician anxiety issue. Another piece that I really worry about is that as fewer and fewer clinicians get experience during training and early in their careers using lithium, I wonder if this then becomes something that they're less likely to reach for later on, perhaps when they do have that treatment-resistant patient. Is that something you see?
Yes, I think people become comfortable using one drug for one illness or a couple of things. And lithium really takes experience and confidence in the benefits of lithium.
So maybe this is a nice point where we can start talking about lithium and the actual efficacy data in children and adolescents.
So I think, first of all, before the Best Pharmaceuticals for Children Act, which is how we got lithium studied, lithium was grandfathered in for people 12 and up on no real data, just based on adult studies. In the early 2000s, 2 federally funded trials said, let's take a real look at lithium. The first one was treatment of early age mania, and that was a real-life head-to-head comparison of lithium, valproic acid, and risperidone in kids 6 to 16 with bipolar 1 mixed or manic. And in that trial, risperidone was the most effective, lithium came in second, and valproic acid only got 25% of the kids better. The second trial, which was happening at the same time, and Children's National did both of the trials, I'm very proud to say, was the BPCA trial, funded through the National Institutes of Child Health and Development. And this was first a dose-finding PK study to figure out how do you need to dose youth with lithium and how rapidly can you titrate up to get an effective level. And then in the part 2, or COLT, Collaborative Lithium Trial, COLT 2, it was the actual double-blind, placebo-controlled trial where 2-to-1 youth were randomized to either lithium or placebo.
So you're twice as likely to get lithium as placebo.
Correct. And followed out for 8 weeks to look at that reduction in manic symptoms on the Young Mania Rating Scale. And what they found was lithium was superior to placebo by week 8, and the effect size in that trial was 0.53. So it was the combination of the findings from the COLT trial and the TEAM trial that led the Food and Drug Administration to label lithium for both acute and maintenance treatment of bipolar disorder in youth 7 all the way up to 18.
And that's one of the few FDA-approved treatments that we have for those phases in youth, correct?
Correct. Most of the antipsychotic trials for bipolar disorder are 13 and up or 10 and up, and acute only except for aripiprazole, which also has a maintenance indication.
So thinking about pediatric patients versus adults, obviously we've used lithium in adult patients across depressive disorders, primarily adjunctively, but in bipolar disorder, as well as in other conditions. How does the evidence for lithium use in adults, or perhaps the indications, differ compared to pediatric populations?
So I think in adults, you use it a lot more for recurrent major depression, either as a primary or augmenting agent. And you will also use it, of course, for bipolar disorder. In youth, there are some small open-label studies. Barbara Geller did one of them looking at it in bipolar depression. And we certainly have used it as well to augment kids either with bipolar depression or recurrent major depression where they're a partial responder.
What's the evidence for that augmentation strategy in partially responsive unipolar depression, either in adolescents or children and adolescents?
There's no double-blind evidence. It's much more anecdotal and case series.
So it's what we call that empiric evidence, which sounds much better, right?
It does. But if you think about it, lithium increases serotonin levels, and so that's part of the reason that it might work for recurrent major depression that's partially responsive.
Thinking about that patient with recurrent major depressive disorder who's perhaps a candidate for lithium augmentation, are there specific clinical features that may make you think this is an ideal candidate for lithium versus maybe this is a patient who would do better with another augmentation strategy?
I think one of the things that I always think about is what's the family history? Are there bipolar patients in the family? Especially if there are bipolar patients who've been lithium responders, then I'm much more likely to go down that road. Instead, if I've got somebody with no bipolar in the family and maybe other people have done well, antibupropion or something like that as an augmenting agent, I may turn in that direction. I do want people to remember that lithium, even in children, and now I'm thinking about the LAM study, the longitudinal assessment of manic symptoms, reduces the risk of death by suicide. And that's been in a couple of different studies, including the LAM study, but also in some of the larger Scandinavian studies where they have data on many, many people and they're looking at outcomes. My philosophy is everyone with bipolar disorder deserves a lithium trial.
Coming back maybe to that unipolar depressed patient, I know you mentioned family history of bipolarity. Are there specific clinical features that may make you think that this is more of a candidate for lithium augmentation? Perhaps mixed features or subsyndromal manic symptoms or a co-occurring anxiety or a lack of co-occurring anxiety? And it's okay if there aren't. I'm really just curious.
I think the mixed features are one of the things that push me in that direction. The anxiety, I'm much more likely to try a different antidepressant strategy because a lot of times those are more responsive to antidepressants.
So let's dig in a little bit more into the efficacy story. So we know we have data supporting its use in children and adolescents. We know that we have data in adults. How do the two compare?
It's been a long time since I've done adult work, and so much of the newer adult data really talks about all the other agents, the anti-epileptic drugs, the antipsychotic medications. And there haven't been a lot of long-term studies in adults with lithium monotherapy versus other agents the way there were in like the pediatric team study where it was a direct head-to-head comparison. We do know from the adult studies that lithium is protective against suicide in adults, and many adults are on polypharmacy for bipolar. And one of the nice things about kids is you can always try monotherapy first, and they haven't been through 8 other agents and failed everything.
This is one of those situations where we're actually lucky as child and adolescent psychiatrists. We get to intervene a little bit earlier in the course of the disorder. So let's dig into the dosing. Let's say we've found a patient that we really think deserves a trial of lithium. How do we dose it? I guess actually we need to decide what mood state the patient's in, right? Let's assume this is an adolescent, perhaps with a mixed or manic episode.
So then they can go on lithium as a first choice. And with the studies that we've done, we have direct dosing information. So based on the Colt study, you start somebody less than 30 kilos, so that's 66 pounds in U.S. numbers, at 300 milligrams twice a day. If they are more than 66 pounds or 30 kilos, you start them out at 900 milligrams a day. If you are dosing per the guidance, after 3 days without a level, you go up by 300 milligrams. So your smaller child would be on 900 milligrams a day. Your larger child would be on 1,200 milligrams a day. And then 5 half-lives later, so basically 3.5 or 4 days, you could check a level 12 hours, 10 to 12 hours after the dose.
So a trough level 10 to 12 hours after the dose. Now, I want to go back to that because you said 900 milligrams. I'm assuming that's divided 450 BID. So we're getting a BID dosing regimen, but we're checking a 12-hour trough. How does that work?
I give medicine to most patients at 7 and 7, and then you could get a trough level. You'd give that nighttime dose maybe a little bit later at 9 o'clock, and then have them come in at 7, 8, 9 o'clock in the morning before their morning dose and see what the level is.
So what do we do with the levels? What are we shooting for?
We're shooting for a serum trough level of 1.0 milliequivalents per liter. In both of the trials on lithium, funded by the federal government, we saw that benefit was best at a level of 1.0 or higher.
So that's a trough level of at least 1. Could I go a little higher? Could I get away with going a little lower?
You can go a little higher. I think when you're really initiating treatment, you do not want to go lower because you may get a suboptimal response. Now, once somebody's stable, you can have another discussion about going lower. But in the beginning, when you really want to see, is lithium going to work or not, you want to go 1.0 or higher. I'll tell you something, though, and this is for all my pediatric colleagues. Many of the labs at your children's hospital will see a level of 1.0 or 1.05 or 1.1, and they will say, danger, Will Rogers, too high.
Yep. And they will call panic level.
And they will call a panic level. We, in the lithium trial, Colt, dosed to 4 stopping points. Serum trough level of 1.4 milliequivalents per liter. Intolerable side effects like persistent vomiting. Clinical benefit like resolution of your manic symptoms. Or greater than 40 mg per kilo per day.
Greater than 40 milligrams per kilogram per day.
Yep.
Did you find any evidence that tolerability was level related? Or was it just too variable? Or were there specific side effects that did tend to correlate with level, or I guess putting clinical pharmacology terms, exposure?
Some side effects certainly correlated with preparation. So in the clinical trials, we used immediate release, and clinically, I used controlled release. So GI side effects were the toughest, especially with our rapid titration. And Dr. Barbara Geller, who was the proponent of lithium in the team study, used to say, if you gave somebody a high-fat breakfast, think pizza and donuts, so the ideal college student breakfast, you were much less likely to have that GI upset and nausea than if you only had a piece of toast and a glass of milk.
I'm assuming that that's probably because of slowed absorption, and because of that slowed absorption that we decrease the maximum concentration Cmax, and we certainly know that many of our side effects across many classes of medication tend to have Cmax-associated side effects. Is that the same situation here?
I think it is. And I think some people are just more susceptible to the gastric upset than others.
Are there any strategies you found to manage those GI symptoms in pediatric patients, other than ensuring that they're taking it with food, perhaps then slowing absorption and lowering that Cmax?
The other thing we'll do certainly is using the controlled release preparation. So there's a 300 milligram CR tablet and a 450 milligram CR tablet. And those are much more stomach friendly, if you will. The other thing we will sometimes do is, rather than dividing the dose evenly, so let's say that you've got somebody on 1,200 milligrams a day and you're taking 600 in the morning and 600 at night, we know most of our patients are going to have a small breakfast and a larger dinner. We might top load the dose so that you're taking 300 in the morning and 900 at bedtime.
So that asymmetric dosing strategy. But it sounds like that's going to complicate interpretation of your trough lithium level. How do you account for that? Is there a fudge factor?
There's not really a fudge factor. And in the end, you're still shooting for that trough level. And we do pretty well just giving it once the bigger dose in the evening and still have decent coverage during the daytime.
Let's unpack that dosing strategy a bit more. And this may be one of those situations where we certainly know that children are not just little adults, but many of our adult colleagues will dose lithium QHS. And I think the thought, or what they might say, is that it perhaps has some nephroprotective effect, and they might make the argument that lithium clearance is a little bit faster overnight and that there's some other advantages. Now, certainly one of the things that we know in the pediatric population is that they have much faster creatinine clearance, and they're actually clearing the drug much faster, which I think you've actually looked at in your studies. So is QHS dosing something that we should do? Is it something that we should avoid doing? What are your thoughts?
I just can't give it once a day, especially in the younger kids, because you'll never get an effective level. They're just too good at shooting everything out through their kidneys to possibly keep a level with once a day dosing with the currently available extended release preparations.
So along those lines, most of the studies have used BID dosing. Are there situations where, I hate to say this, we might need TID dosing with lithium in kids or in younger kids?
For some of the younger kids, what we looked at in COLT 1 was BID versus TID dosing, and there wasn't a big difference in terms of being able to achieve and sustain a level. The place where I would use it is if you had dose-related side effects, so that if you were giving somebody, let's say you had somebody on 1,800 milligrams and they had a marked tremor, you might, instead of giving 900 twice a day, you might split the dose up a bit so that they didn't have such a bad tremor.
So I think you really set the stage for maybe the next few questions, which are related to side effects. And for me, it's less of an issue of how to use lithium. It's more how to manage these side effects, and ideally, if I could, how to predict these side effects. So let's run through some of them. Can you tell us just in general about the safety concerns with lithium in pediatric patients?
So there are a couple of different sort of clusters of side effects that we need to think about. We've already talked a bit about kidney side effects, and one of the biggest issues with lithium toxicity, say in an overdose situation, would be the effect on the kidneys. And once your lithium level is over 2.4, you're going to start to have ataxia and confusion and marked gross tremor. And then it's time for emergent hemodialysis. So somebody who really has a high lithium level, let's say they took a month's worth of lithium in a suicide attempt, you need to get them to the emergency room or the PICU and get them on dialysis to get that lithium out of there and protect their kidneys.
So let's run through some of those other side effects. You mentioned the renal side effects, and we'll maybe talk a little bit more about those later. But let's start with the tremor. I see this a lot. You alluded to the fact that this is probably exposure related for many of our patients. Do you see any predictors of who develops the tremor?
The one big predictor of who develops the tremor is, number one, are they taking other agents? So things like valproic acid and lamotrigine and even some of the antipsychotics are all associated with tremor as well.
So taking two out
that cause tremor is going to put you up at a higher level or a higher risk, if you will. The other thing is family history of tremor. So I'm thinking about one of the people that I have in my office who's not on a super high dose of lithium as a teenager and only on about 900 milligrams a day and has a good level. But dad has a familial resting tremor. And so my patient, even with a normal level, even down to 0.7 at times, has a tremor. And that I think is really familial. And it's just in that person with a family risk on a medicine that is associated with tremor, has a tremor.
So what do you do with the tremor? And let's say this is one of those patients that's really responded beautifully to lithium and perhaps even to up the ante. They've not responded to anything else, but they have a tremor. What do you do?
We try and, again, give more of the medication in the evening. And then we work on, sometimes people use beta blockers for tremor. That, of course, puts you at risk for getting depressed, but sometimes they're effective. And we just work with the patient. A lot of times the big issues with tremor are around eating, especially if you're nervous eating in social situations, your hands may shake. And around handwriting, but now with the ability to dictate and type, the tremor for handwriting is less of an issue.
So how often do you use propranolol? And when you do, how do you dose it?
I use it not very frequently. And when I do, I just start out at like 10 or 20 milligrams a day and see how the patient does and see if they tolerate it.
I think that's very similar to what I do in terms of I tend to be on the lower dosing range with regard to propranolol. I think the situations where I've really struggled have been places when I have a transitional age youth who is involved in an art program and really needing to do, fine motor activities, or in nursing school where they're needing to, draw up medications into a syringe and so forth. And I've really had reasonable success with propranolol. And of course, as you alluded to, lowering the dose. In terms of endocrine side effects, certainly we all know that lithium can be associated with myriad endocrine effects, including hypothyroidism. How common was that in your studies?
It was actually much more common in kids than it is in adults. And we saw bumps in thyroid-stimulating hormone, TSH, frequently by the end of an 8-week clinical trial. We did not see everybody become clinically hypothyroid. So in addition to the elevation in TSH, you need to have a lowering of your T3, T4 before you're clinically hypothyroid. But one of the things that we do is we would get a baseline set of thyroid function tests and then get a follow-up at the end of 8 weeks just to see where you are.
Do you recommend that clinically as well?
I do that clinically as well. The other thing I would say is if you've got a patient who is stable on lithium and they suddenly become depressed, check a thyroid. because many times it's that hypothyroid associated depression that is not, in fact, a mood swing on lithium, but is a reaction to the lowering thyroid status. The other thing I want to remind people is you need iodine to have healthy thyroid function. And many of us in the United States used to get iodine in two ways, through iodized salt and through leavening agents in bread that contained iodine. Because people often avoid salt because it's bad for you, and because people don't always eat bread products and they're using different agents to make bread rise now, the sources of iodine in your diet are limited because people aren't eating seaweed and shrimp outside of places like other countries where that's a large part of their diet. And so people may also be getting lower lithium levels, lower thyroid function on lithium because they're not getting enough iodine in the diet. And the reason that that is important is the thyroid gland wants to make thyroid hormone, and it's looking for an ion. And when it's looking for iodine and it's not there, but lithium is, it takes lithium and tries to make thyroid hormone with the lithium. And so it just doesn't work. So one of my recommendations for people is to make sure you're getting some kind of either iodized salt in your diet. And we want people to be on salt in their diet when they're on lithium so that they don't retain lithium instead of sodium chloride, and so that you can continue to have a healthy thyroid status. If you like shrimp, go for it. If you like seaweed and seaweed crackers and things like that, that's another source that's very high in iodine. Yeah. But those are important things to know and understand.
So in terms of that patient that has had a bump in their TSH and then subsequently, let's say, develops more depressive symptoms and a depressed free T4, T3, do you work that up as hypothyroidism, or do you just treat with L-thyroxine? What do you do?
We just treat with L-thyroxine.
It's always nice to hear somebody doing the same thing that you do clinically.
The endocrinologist just sort of like, oh, well, you can stop the lithium. And I'm like, no, we're not going to stop the lithium. It works for the patient. So we're gonna treat the drug-associated hypothyroidism.
But I would see that as many ways as the same as we do with other medications. For example, when we have weight gain associated with an SGA and it's really working, we'll add metformin or we'll add some other mitigating strategy. What about in terms of parathyroid effects or other endocrine effects? Anything to say in kids?
We haven't really seen that a lot. We haven't seen somebody get pan-hypopit or anything like that unless they have other things going on. I think the other big issue we see with lithium is dermatologic. And it's not always something we think about. So I sometimes like to say that if you have a skin condition, no matter what it is, on lithium, it's going to get worse. And this was fascinating. With adults, we know adults with psoriasis, if you have a psoriatic patch, maybe under your elbows or around your scalp, and you go on lithium, it flares. If you have acne, so think about your adolescent patients, and you go on lithium, it spreads very frequently. You have one or two pimples on your cheeks and nose, and then all of a sudden you have an expansion of your pimples. But what was fascinating for us when we did the studies in the younger kids is many of those children have eczema. And I'm interested in skin stuff. So I said, let's see what happens with our kids on lithium with eczema. The eczema spread too. Absolutely. And so we would see just the way you'd have patches of psoriasis in your adult patients, you might have small kids who had antecubital or posterior popliteal fossa, patches of eczema, and it would spread as well. So there's just something about lithium and skin that's absolutely fascinating in terms of sort of chronic, almost like they're not really all autoimmune skin conditions, but they're skin conditions, and lithium did something and they increased.
Interesting. Dr. Robb, I'd like to ask about another endocrine side effect that I certainly see in many of my patients that I've treated with lithium, and that is the polyuria polydipsia. I know that there's a lot of work that's been done with this in the adult world. I'm curious how frequent that is, first of all, in children and adolescents. How do you assess it, and what do you do with it?
An important side effect to look for and to talk about. So in general, people on lithium should be having salt in their diet, and they should be drinking fluid. They should not be trying to fluid restrict. And sometimes parents will say, my child is drinking more, and they're going to the bathroom a lot. But that's a very vague answer, isn't it, as a clinician? So one of the things you can certainly do is ask the parent how many bottles of liquid, if you have a water bottle or a sports bottle or whatever you're taking to school, is your child drinking? And how often are they going to the bathroom? And specifically, how many times are they waking up during the night to go to the bathroom? Because sleep disturbance isn't good when you have bipolar, especially for mania. So if somebody's drinking, 3-4 liters a day, you have to be worried about it. One of the easiest ways to check for the polyuria and polydipsia, you can always do a 24-hour urine collection. That's easier in the hospital than it is at home, and it's almost impossible to do at home. But the other thing you can do is check a specific gravity midday. Not first thing in the morning where they've not had anything to drink all night long and their urine's going to be concentrated, but let's say after school, get a urine-specific gravity, and if it's like 1.00001, then you're concerned that they're drinking a lot. If they can fluid restrict and concentrate their urine, it's probably then due to polyuria and polydipsia. When that happens, some people will use agents to help control that. What do you use?
Well, I've recently, based on some of the work that Jonathan Meyer has talked about at NEI, use amiloride in some of my older adolescents. I've actually been incredibly surprised at how effective it can be with the polyuria, particularly the overnight polyuria.
And that works quite well. And you can just dose it the way they do in adults and just sort of start at the lowest dose and see if you get a clinical response. You don't have to go all the way up. I think the other thing we'll sometimes do is drop the dose, especially if they're on another agent. They might be on, say, lithium and lamotrigine or lithium and a second-generation antipsychotic, and you drop the level and you drop the dose, and sometimes they then start drinking less, and sometimes even their lithium level goes up. So one of the most fascinating dilemmas I had was a patient that had fairly bad bipolar disorder and was on lithium and had responded pretty well, but we ended up hospitalizing him when he had a tough time. And he was on a reasonable dose of lithium, but we couldn't keep his level up. And the reason we couldn't keep his level up was he was drinking 5 liters a day of fluid. And his mom had said he was drinking a lot, and we just had no idea how much a lot was until we got him in the hospital. And then his level started to creep up because you can't get water all night long in the hospital. And his level, we dropped his dose and got him down to a lower level of lithium and a better dose and less polyuria and polydipsia. But sometimes the level, even at a high dose, your patient's taking the medicine, they're on, let's say, 1,800 milligrams a day or 2,400 milligrams a day, and you're only hitting a level of 0.6 or 0.7, and nobody's kidneys are that amazing. They're probably drinking a lot and just literally flushing the lithium out of their system.
So once again, in medicine, it comes down to getting an accurate history. Amazing. I want to stick with the kidneys for a minute. So in the adult literature, there are thresholds that one might use to be concerned about a decrease in GFR. Are there similar thresholds at which we should be concerned in a pediatric patient, say a drop of a certain percentage or a drop below a certain threshold? Is there something like that that should trigger some discussion with pediatric nephrology or something along those lines?
We haven't really got the data long-term on patients in large registration databases the way they do in adults where there are lithium registries. I get more concerned if somebody's BUN and creatinine start to go up, even if they're not dehydrated. And then I have a conversation. I had one child who had nephrolithiasis and had been seen by the nephrologist for that reason. So we always kept him on a much lower lithium dose and a much lower lithium level, and it still made a difference in his overall mood functioning. So we kept it on board, but we never went up to a level of 1.0 because of the prior kidney issues.
So it sounds like some collaboration and flexibility around the dosing.
And that's an important thing back to the kidney stuff. For patients that you may have in your clinic who are on topiramate, either for migraines or for epilepsy, they put you at higher risk of nephrolithiasis and lithium toxicity because, again, they're both renally excreted. And so you want to be really careful if you've got a patient that's on topiramate.
So again, those drug-drug interactions are so important when we're talking about lithium in adults and in pediatrics. So we've talked a little bit about the endocrine side effects. We've talked about the GI side effects. We've talked certainly about the tremor. You've alluded to the way in which lithium is cleared through the kidney, which I think probably also brings us to issues related to toxicity and certainly those drug-drug interactions. And I would say probably also in the pediatric population, drug lifestyle interactions. Can you talk a little bit about those and also perhaps about how you have the discussion of those things with the family?
So I think one of the places you need to be cautious, if you will, on lithium is when somebody needs to get high-dose nonsteroidals. So that doesn't mean you have menstrual cramps and you take 400 milligrams of ibuprofen and it's once a month. That's fine. I'm not going to be concerned about your lithium level with a single dose or, 72-hour dosing or something like that. But let's say instead that you have a high school football player who is exercising and gets a groin muscle pull, and he goes to the sports medicine doctor who puts him on 800 milligrams of ibuprofen TID for 14 days. Then I want a lithium level. And the reason is that they compete for excretion in the kidneys. And your lithium level, which has been stable, can creep up. The other place you need to check about your lithium level is if you have not food poisoning, because that's 24 hours, but let's say that you've got some kind of prolonged stomach bug where you're vomiting with a high fever for 3 or 4 days and you're still taking your lithium. That's one of those times when I'd actually say, you know what, let's take a break. We'll wait until you can keep some food down and then restart your lithium. We know what your effective dose is, but you really don't want somebody to get lithium toxic because they're vomiting.
So that's one of the few situations in which you would actually hold a lithium. And again, just to maybe summarize what you said earlier, in these situations where we have vomiting and we have diarrhea, we're losing electrolytes, we're losing sodium in particular. And what the kidney is then going to do is it's going to try to
grab
hold
any
on
cation
to,
it can find.
Right, some cation, which in this case tends to be lithium, which then exacerbates the lithium toxicity, which exacerbates the nausea and vomiting, which causes more fluid loss, which then increases the lithium level. And we really get into a terrible cycle. Let's shift gears and talk a little bit about the conversation with the family and with the patient. How do you approach the discussion around starting lithium?
I first approach the conversation about talking about bipolar disorder. What is it? What's the prognosis? Why early treatment is so important in terms of returning functioning, getting children back to school, avoiding kindling and long-term sequelae of untreated bipolar disorder. And one of the most important things I talk about is that the onset of bipolar symptoms is 3 to 5 years before the onset of comorbid substance use disorder. And we have a golden window to avoid self-medication with substances if we get your child's bipolar symptoms under control. And we know that lithium is effective in children 7 and up, and we know it reduces the risk of death by suicide, and we only have 2 agents that reduce the risk of death by suicide in all of psychiatry. That's lithium for bipolar disorder and clozapine for schizophrenia. And when death by suicide is our worst outcome, any chance we have to reduce that risk or prevent it altogether is an important chance to take.
Absolutely. And as we're thinking about these risks and benefit discussions, one of the things that's always bothered me in terms of how we frame these discussions is we don't often think about the risk of not treating or under-treating. And that's why I really like what you've said.
I think the risk of under and not treating is what I used to see when I ran the bipolar clinic at the National Institutes of Mental Health. Adults would come in and they would say, Dr. Robb, you have to treat my 8-year-old. Lithium saved my life and my child is having the same symptoms at 8 that I did. And at the time, I was not a child psychiatrist. And I said, just go see a child psychiatrist in Washington, D.C. They'll take care of you. And they said, you don't understand. Pediatric psychiatrists don't believe in bipolar disorder. They don't think it exists, and they don't want to treat it. And it brings me back to taking care of a young child who was on our inpatient unit recently who had a developmental disability and all the signs and symptoms of mania. And I talked to the outpatient doctor, talked to the family. I said, I really think this is mania, and here's why, all the symptoms. I think we need to try lithium. They've been on an antipsychotic. It's not holding them. The manic symptoms are obvious, and we need to try. And in the hospital, that's what they did. The child had been there a long time, got better in a week. I was just like, and now the child's an outpatient, and the parents are still scared about lithium. They're happy to take an antipsychotic, and that has its own collection of side effects. But lithium for some people really means serious mental illness, and it's scary to need that kind of medicine.
It is amazing how not only is there the stigma associated with the illnesses that we treat, but with some of the treatments that we actually have in our toolbox, ECT, some of the other interventions, lithium, etc. Let me finish with just some of your general thoughts in terms of where we're going. What do we still need in terms of additional data to help us better use lithium in pediatric patients?
I think one of the things we need is a good indication of who will be a lithium responder. I think the one thing we have is family history of response to lithium. But if I have 50 bipolar kids walk through the unit and come on in and start on medicine, I still don't know which of those 50 will be a lithium responder, who's going to do better on lamotrigine, who's going to only need an antipsychotic. And if we could tailor our treatment the way the oncologist can cancer genes and tailor their treatment to the genetic abnormality that's leading to the cancer, we would avoid what we sometimes have to do now clinically, which is trial of medicine and error.
So in terms of any specific things that we may be starting to look at with regard to identifying maybe endophenotypes that are more lithium responsive or less lithium responsive, just based on what you've seen clinically, based on what you've seen in COLT?
I think what we saw clinically, actually in the team study, when they compared risperidone, lithium, and valproic acid is that kids who were on concomitant stimulant treatments for ADHD were more likely to respond to risperidone and less likely to respond to lithium. So some of the comorbidities may point you in one direction or another. But what was fascinating is if you went through the team database and you removed the kids who were on stimulants for ADHD, and you then did a head-to-head comparison of lithium and risperidone, they were equally effective.
Interesting. So it's a question of, is it the treatment? Is it the disorder? Is it some interaction with regard to the two? We don't know, it sounds like, really.
We don't know. But I think that the most important thing is it's a real diagnosis in kids. And I think we do a disservice to children when we say that irritable, out-of-control behavior is DMDD.
And what is DMDD, maybe for some of the listeners that haven't heard that term?
Disruptive mood disorder with dysregulation. And it's a new diagnosis that most people who take care of bipolar patients don't ascribe to. And it's used as a way to avoid diagnosing bipolar. And I think that's a huge disservice when I think back to my adult patients who'd been sick for 5, 10, 15, 20 years. And there's lots of evidence in the adult literature that people go 15 years before getting an accurate diagnosis in their mid-30s. So then everybody learned bipolar disorder has an onset in your 20s and 30s. But what about all the people that have manic symptoms in middle school and high school and have a cycling episodic illness? Those people deserve an accurate assessment, deserve an accurate treatment, and the ability to move on with their life, to go to college, to get a job, to have a family.
So what you're really reminding us of, once again, is the damage that can be inflicted by misdiagnosis and inappropriate treatment and delayed diagnosis. Well, it's been my pleasure to be here with my good friend and colleague, Dr. Adelaide Robb. I certainly learn something every time I talk with her, and certainly have today as well. I hope that you have at home. Thank you again, Dr. Robb, for taking the time to talk with us about lithium.
And Dr. Jeff Strawn, it's been a pleasure for me too. Someday we'll have another conversation about what to do to treat anxiety disorder in people with bipolar, because the SSRIs cause us trouble.
And I also want to bring you back for a discussion about that DMDD.
Oh, I'd love to.
We'll do it. Thank you again, everyone.
Thank you.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.